Alrighty, so today we have a debate. Should full agonists be prescribed to patients with OUD and chronic pain? I am thrilled to invite two of my favorite teachers and mentors from residency, Mia Sorcinelli and Ryan Dono, up to the stage, who do not know that I have photoshopped their heads onto a WrestleMania picture. I will say I did this when I was on inpatient service and the residents saw me doing it and they were like, literally, what are you doing? Um, none of us have any disclosures. I do want to disclose a little bit about bias, and this will apply really to the entirety of the afternoon. So we are all here talking about folks who experience significant stigma and bias. And many of us as members of the medical profession perpetuate that bias and stigma. And so we're really at risk of that as we're having these conversations that are really hard. And so I really want to invite everybody in the audience to feel comfortable saying oops and ouch if there is a message that has been sort of incorrect or terminology was not right. I think we want to assume good intent of everybody here, but we also want to sort of come correct. I think the other thing I want to bring up is that talking about SUDs and chronic pain in particular tends to provoke very big feelings. Everybody has a lot of feelings on this subject. And so I would really encourage folks, feel free to disagree with what's said, feel free to have differences of opinion, but really stick to I statements and think about how you feel and what your practice is rather than saying that somebody else has done something, right? Because that really just gets in the way of us having a fruitful conversation and learning together. The other piece is that we're about to experience a wonderful debate, and debates make an assumption that things are black and white, and that is very much not the case in the world that we are talking about. So with that in mind, our objectives for this debate are really to talk about the pros and cons of providing full agonist opioids to patients with a history of OUD, and to start to develop a framework to review complex cases, which is what we will do next. The debate will be structured with a brief case introduction. Each of my debaters will have a yes or no position that they will expound upon for 10 minutes each, and then they will be allowed 5 minutes to rebut one another, and then we will close. And so it will start with a clinical case. This is a 55-year-old female with a past medical history of moderate to severe chronic pain. She was diagnosed with rheumatoid arthritis in her 30s, was treated with DMARDs and oxycodone chronically. Her oxycodone use escalated relatively dramatically, eventually stopped by her provider, and instead was using oxycodone that she purchased from friends and was mostly sniffing, sometimes injecting it. She was eventually started on buprenorphine and managed to enter recovery from opioid use disorder, which has continued for years. But unfortunately, her rheumatoid arthritis remains very challenging to treat. She's currently on multiple agents. She's been on chronic steroids for nearly a year, and as a result has had several fractures, has multiple joint erosions, etc. She follows closely with rheumatology. She has an excellent pain regimen, and her DMARDs are all essentially optimized, and she's doing PT and OT and aquatherapy and acupuncture and all the things that you have asked of her. And nevertheless, she continues with really worsening pain due to flares that are refractory to interventions. She has recently purchased oxycodone from friends for relief because of the severity of her pain and the lack of efficacy of your treatment regimen. You have expressed to her that likely those are pressed pills, and she has intentionally purchased fentanyl once, which she was very, very fearful about, but felt that she really had no other choice. And so today at your visit, she is asking to restart oxycodone on an as-needed basis for very bad days. So, an easy case. All right, I'm gonna turn it over to my debaters.
Gonna stand at the podium because talking with a mic feels too TED Talky to walk around. Good afternoon, everybody. My perspective comes from that of a primary care physician in family medicine. I also wanted to just note that there's two sides to this debate, and I picked one side. So if you're going to demonize anything, demonize the message, not the messenger, please. So I'm going to present my argument to you all with the more trivial issues and then ending with my more salient and important ones. So please bear with me as my argument crescendos to its grand finale. I hope that all of my points you will find valid and that they resonate within your own practice. I have 5 major points, which are based around some of my darkest fears in practicing medicine that also are nearly always present in day-to-day practice. I'll start with my first fear, the fear of the unknown. No one trained me for this. I feel like I am sailing into uncharted waters when I think about prescribing opioids to a person with opioid use disorder. There was no class in medical school. There was no elective in my family medicine residency that taught me the complexities in prescribing full agonist opioids to a patient with a history of or current opioid use disorder. Oh. Yeah, is it better if I speak? How's that? Any better? Is there a volume thing on this? Check mic. Is that any better? Is it better this way? Yeah. Okay. The ice cream wasn't close enough. All right. Where was I? So my first fear is that the fear of the unknown. There are no solid guidelines that I can find. The CDC has some recs that suggest that it's okay with robust safeguards in place. There are no textbooks that I can find outlining how to do it. And on my last check, UpToDate only gives help in the acute care setting. And if UpToDate can't guide me, then maybe I'm not the right person for this job. This patient should probably see pain management. After all, those people have been trained in this. I should add, though, that whenever I do send my patients to pain management locally, they never prescribe opioids. And if they're unwilling to prescribe them, then why should I be the one to do this? My second fear is a fear of burnout. It's way too much work. There are too many obstacles, even if I thought it was worth it. Every time I've tried to prescribe a patient with opioid use disorder an opioid, their insurance company comes in and declines the script. They require that I complete a PA. And even then, they tend to decline to accept the PA. The amount of time I spend chasing around the PA is soul-crushing, untenable, and psychologically distressing, not only to myself, but also to my patient, who is waiting in the wings for an answer about whether or not their pain and the treatment of their pain can be validated by someone in their insurance company. I don't have the capacity in my overburdened, overbooked, overpaneled clinic. Adding opioids to their regimen will add more appointments, more documentation, more work for me and for my support staff. Reviewing the risks, benefits, expectations around expected outcomes, signing and reviewing a controlled substance agreement, measuring a response to treatment, qualifying the need to continue opioid treatment takes a lot of time. The amount of time needed to adequately stratify someone's risk is especially burdensome as well. Per the CDC's recommendation, if screening tools for misuse are used, they should be supplemented with other assessments, such as discussions with patients, with their family and caregivers, reviewing clinical records, reviewing the prescription monitoring program, and toxicology screening data. Where does anybody have the time to do this? By the time I have come anywhere close to getting all of this done, the patient's 15-minute visit ended 2 hours ago. Starting someone on opioids is one thing, but if I am being honest, I don't have the reserve to deal with weaning off of it either. Initially, the patient almost always needs to titrate their dose up and when getting started on these medications. And the process to bring their prescription to a close is often a long, cumbersome road full of obstacles, setbacks, and complications. One study found that patients with histories of substance use disorders are more likely than other patients to receive long-term opioid treatment for chronic pain. This fact kind of scares me. My third fear is the fear of diversion. We were just talking about the DEA. My career these days is focused on the treatment of addiction. I have seen the toll opioid overprescribing has had on communities, families, and individuals. I promised myself that I won't continue to this problem any further. I'm not convinced that prescribing an opioid for pain management has enough solid evidence to support doing so when I know there are legitimate risks to others outside of my patient when I'm prescribing these medications. We know that many who misuse prescription opioids get them by borrowing from another person's prescription. And I will have a hard time forgiving myself if my patient were to worsen our opioid problem in the United States by exposing others to the risk of addiction. My fourth fear is a fear of liability and losing my license. If someone were to review my prescribing habits, then how will I look treating both opioid use disorder and simultaneously prescribing opioids to the same patients? What if that patient has an overdose? The finger to point will easily be directed at me. I know that things can go wrong even with the most cautious and thoughtful approach, including the prescribing of naloxone and ensuring close follow-up with patients. We are all aware that in the course of maintaining sobriety, all it takes is one curveball to get back to a relapse. One iota of stress, one governmental policy change to end someone's insurance coverage, one romantic breakup, a car accident, or a surgical complication leading to a new source of pain, and the patient all of a sudden can find themselves in a full-on relapse. If I'm the one at fault and lose my job, I have 3 beautiful children and a beautiful wife that depend on me to keep my job. But I also have thousands of other patients that depend on me and my services to keep them healthy. It's not fair to them if I lose my license over perceived reckless prescription writing. The outcome scares me to my core. My last and my biggest worry is fear of harming the patient. I took an oath that I hold dearly to my heart. It involves the concept of doing no harm. At UMass, we took the oath of Maimonides, which talks about the constant pursuit of improving my skills as a physician, but always with the lofty aim of doing good to my patients. If a patient has established and maintained their sobriety, this is a sacred accomplishment that needs preservation to the best of my ability. The path to addiction so often starts with prescription opioids. I am truly fearful that my prescription, whether it is intended or not, can be the insult that leads someone to relapse. And can I, in my soul, say that the benefit outweighs the risks when I know all of this? I'm not sure. Here are some facts for some of you evidence-based medicine folks out there that worry me around all of this. Studies have shown that illegal drugs are listed on a substantial proportion of death certificates for prescription opioid-involved overdose deaths. This means that many folks out there are abusing other opioids on top of a clinician's chronic pain prescription. In 2023, the National Survey on Drug Use and Health showed that 3% of all people misused prescription opioids, and the most common reason for misuse was uncontrolled pain, so 70% of people. This worries me because my patient with opioid use disorder will be more likely than not to have uncontrolled pain. The Agency for Healthcare Research and Quality has reported that it is known that opioid prescribing puts people at high risk of overdose. But they also report that there's no validated, reliable way to predict which patients will experience serious harm from opioid therapy and which patients will benefit from it. This sounds like a recipe for disaster. And other research has shown that tapering or discontinuing opioids in patients who have taken them long-term can be associated with clinically significant risks, particularly if opioids are tapered rapidly or patients do not receive effective support. I can handle the slow taper, but I'm not sure I can ensure effective support in a patient's life 100% of the time. It's certainly my priority in my work that I do in medicine to ease my patients' suffering, augment their health, and do so with compassion and caring. It's my role to help patients pursue treatments that will improve their health, but also not cause harm. I need to be able to provide this care with certainty using evidence-based approaches that are informed and proven. The prescription of opioids within opioid use disorder brings up a lot of uncertainty for me, and it makes my 5 fears a worrisome reality. And those fears are the fear of the unknown, a fear of burnout, a fear of diversion, a fear of losing my license, and a fear of harming my patient. And it's for these reasons I can't commit to involving the prescription of opioids in a patient with current opioid use disorder. Thanks.
Can you hear me now? Hi, I'm Mia Sorcinelli. Thank you, Dr. Dono, for sharing your concerns with me and with our audience. And here are some of my thoughts kind of organized in a similar lineup to reply to Dr. Dono's arguments, which I do think are compelling. Certainly fear of the unknown is very much based in reality. So if anyone here has ever seen me do a talk at another conference, you know, generally I prepare for talks by combing through and trying to find the latest evidence updates. And I always go to that BMC, alcohol, other drugs and health. And I look at, you know, what journal articles came out in the last year. And really there's nothing out there to guide us in this sphere. There are no guidelines, no real evidence to support prescribing or not prescribing chronic opioid pain medication to patients. And I guess when I'm thinking about this, I'm thinking about a patient like the one we talked about who is on a medication for opiate use disorder, whether that's methadone or buprenorphine. And so for sure, you know, I'm stepping into uncharted territory by arguing that it's something we should consider. You know, these patients are historically marginalized by the healthcare system. And it doesn't surprise me that there's a lack of evidence because people want to investigate more like exciting things and they don't want to dig around in a methadone clinic and investigate the concerns of these patients who are not in the mainstream. If anyone here wants to start a research project, I think it would be amazing. I think in the current climate, it's unlikely they will get big funding from the feds, but you know, I think this is an area where we need more robust medical research to guide us. Just because we don't have the evidence does not mean it's bad or necessarily dangerous to try this thing. It just means we don't have the evidence for it. So I believe it's worth considering in certain patients. These patients deserve our time and our care. So I'm also a family doctor, just like Dr. Dono, and an addiction medicine doctor. I work in an underserved community. A lot of these patients have transportation problems, insurance problems. And so usually, you know, even in my regular primary care clinic, I may see someone who I want to go see endocrinology, but they can't make it. And so I really try to become the doctor that that patient needs. So maybe I'll go on Maven and I'll do an e-consult and I'll find out what dose of methimazole they need for their hyperthyroidism. In the same way, you know, I'm the addiction medicine specialist in the room with the patient and I'm their family doctor. So who better than me to partner with my patient and work on this complex situation that they have? I might be the person who's the most comfortable managing their chronic pain and their opiate use disorder. I also work in a methadone clinic, so I probably would feel better about doing this than other people. We know from our patients, if we talk to and listen to our patients, we know that someone on buprenorphine for opiate use disorder who, you know, is in a car accident and breaks their arm or goes to the dentist and gets 5 teeth removed, that they do get pain relief from short-acting opiates for their acute pain. And we know if we talk to our patients that some of their chronic pain might be helped by those acute doses of short-acting opiates. So I think it's reasonable to theorize that there may be some benefit for patients taking full agonists in addition to their MOUD. In terms of feeling fear of burnout and overwork, yes, Dr. Dono is correct. I'm not going to argue with him too much on that, but I would say that managing any patient with a complex medical condition is hard and can be exhausting and can cause burnout, right? I'm a family doctor, so I see patients with diabetes, kidney disease, hypertension. I'm juggling those 3 conditions when I'm looking at their med list and I'm, you know, adding this medication, adding that. What are the side effects? You know, we in primary care deal with this all the time, and our specialist colleagues do too. So we know that these are hard patients. We know that there are other hard patients that we can take care of too. So for example, you know, if a patient needs a GLP-1, they're all the rage, they require a lengthy PA, I'm going to do that PA for that patient because that's the right thing to do for my patient. So even if it's hard and annoying to manage complicated patients, I'm going to keep doing it regardless of whether it's related to pain and opiate use disorder or other medical problems. In my mind, they're the same, or they should be treated the same by us. I also think I love taking care of patients with opiate use disorder who are in treatment because it's all out there on the table. They're not trying to hide anything from me. I often know them really well. I've been taking care of them for many years. I know the backstory. I know how it got started. I know, the low points, and there's no secrets there. I much prefer dealing with that patient and their complicated problem than with someone who is trying to maybe mislead me or, convince me that they need a higher dose of their pain meds, but I'm not quite sure what's going on. And maybe they're hiding some things and they're not telling me that their use is getting out of control. So I would rather the patient who's described here, who's kind of laying it all out in front of me, telling me the truth about what's going on so that we can work together. I think, yes, those patients are complicated. It can be scary, but to me, it's less scary than the patient who's kind of lurking in the shadows and not sharing what's going on with them. I also think it's sad because a lot of our colleagues are sort of quote unquote refusing to prescribe opiates to anybody out there. So, I'm a mixed app consultant. I work with Chris. We get phone calls all the time. I'm a doctor. I'm taking over these 37 patients from Dr. So-and-so, but I don't prescribe opiates. So you have to help me get all these patients off their opiates in like a day. And I actually think it's unconscionable to say I don't prescribe opiates. You can't just not prescribe an entire class of medication. Sorry, says me. You can quote me on that. And in that same vein, if I have an opioid use disorder patient who's on BUP, I really don't think it's just for me to just dismiss them out of hand without partnering with them and working closely with them. Our jobs are hard. Our patients' jobs are hard. Being in recovery requires a lot of effort on the patient's part, right? We know this. And so we owe them the same effort and same compassion to work with them to manage their needs. I love working with these patients, as I said, and I find that, it is a counterbalance to the burnout that I feel in clinic, because I just feel elated when people's lives are better and when they're feeling in a better place. So I would say, yes, taking care of patients like this can be hard and scary, but it can be really rewarding as well. On the insurance side, yeah, currently, I don't know if I have a patient who I've recently tried to get tramadol in addition to buprenorphine. Mass Health was just like, no. And then I worked with Casey, who is one of our clinical pharmacists, and we wrote like a 2-page essay about the patient and her entire life story and why we thought it was really reasonable. And I don't even think they read it actually, because the denial, it was time-stamped about 10 minutes after we sent it, just came right back. They said no. So again, if anyone in the audience has like any Mass Health pull, or maybe we can all get together and do a little study where we look at insurance data, I would love to work on this with somebody, because I think it's really unreasonable just say flat out no for every single patient. Every patient's different, every situation's different. Would I do it for every patient? No, but for certain patients, yes, I would. Fear of diversion. So Chris just gave us a great talk about how you can, I know you didn't say it this way, Chris, but I'm going to say you can get away with a lot of stuff if you document it carefully in your chart, right? That's what you meant, Chris. and so I think the flip side to that is, if we think we know what's going on with our patients' medications, we never know 100% what they're doing with any medication that we give them. I give people metformin, right? And they're like, I have 7 bottles at home. What? Don't give me more refills. Like, what have you been doing with it? Oh, I don't take it every day. I mean, the same thing happens with Adderall and Lyrica, any, oxycodone, Suboxone, take home methadone. We can't follow people home. We can't watch them. People don't take their meds the way we prescribe it. We got to be okay with it. And so again, like, I feel like I'm pretty well versed because of my skill set in addiction medicine with monitoring my patients to the best of my ability. So I'm always checking the PMP, and I'm looking at the PMP, and I'm doing toxicology screening at most visits, and I'm documenting in the chart, and I do the PEG and the this and the that. Often these are patients that I'm seeing more often than I would see my other patients. So that, to me, that's not such a big burden. It's not a reason to not do something that my patient needs. I feel like I can do a decent enough job at preventing diversion that I'm like, I can go to sleep at night and feel okay about it. So in kind of to sum it up, I think we fear liability, we fear losing our licenses. I understand that we fear a board complaint. But who better than the people in this room and the physicians, the NPs, the PAs who are doing this work? We very well understand that kind of Venn diagram of addiction and then chronic pain and then the people in the middle. Like, who better than us to understand where those patients overlap? We know the ins and outs. We know, okay, you're on buprenorphine, you have chronic pain. I gave you 5 oxycodone, it didn't help. Well, hey, what about a methadone clinic? Do you want to talk about it? I know so-and-so down the street at the methadone clinic in my town. Can I call them for you? Can we sit together and do it? I think we know how to do this complicated work. We can carefully document it. We can provide naloxone. We're already providing naloxone to these patients. We can do all the stuff that we're supposed to do to keep them safe. And I think the risk of liability really at the end of the day is probably low, because I'm going to write such a great note that the DEA won't come for me. And then finally, Ryan, I think really compellingly talked about fear of harming the patient, which I understand, and I think that's well-founded. I would argue as well that these patients have already come to harm. They have already been harmed probably by prior colleagues of us who maybe overprescribed pain medications with really no breaks on that system and just kind of let things roll. I just admitted someone yesterday to the methadone clinic where I work, and they were given extremely high levels of oxycodone for several months and then just shut off abruptly, and that led to years of secrecy and an opiate use disorder diagnosis. These patients have suffered a lot. They've suffered a lot of stigma in the system, a lot of undertreatment of their pain, a lot of mistreatment of their use disorders, and so many barriers to care that we've really talked a lot about this morning at this conference. And then, limited access to effective treatments, whether it be buprenorphine prescribers or there was a big cheer when the speaker said, we got rid of the X waiver, which, yeah, is great. But did that really make more people prescribe buprenorphine? I don't think so. I still talk to people who, I don't prescribe that. Why not? You can just write a prescription. Anyways, so, these patients that we're talking about, this patient in the case, or my patient who I'm thinking about, the one who I wanted to give tramadol to, they've already demonstrated an enormous amount of resilience to the world and things that are stacked against them. And so I would love it if I could kind of smooth the way for them going forward. And I worry a little less about them coming to harm from anything I'm doing, because they've already survived so much and they've come so far. Most of my patients on Suboxone, and even many of my patients on methadone, actually are very fearful of being given opiates or, sort of redeveloping their use disorder, right? A lot of them don't want oxycodone. They'll go to the ER and, they'll have a broken bone and they'll say to the ER doctor, no, I just want, ibuprofen. So I think in some ways, the patients who are asking us for pain medication are at the end of their rope, right? They don't know what else to do. And they understand the risk of this medication. And they are asking us to take a risk with them, to keep an eye on them, to kind of keep them in check. And I think sometimes, not always, but many of these patients might be more cautious with the medication the second time around because they know the damage it can do. And then, I really worry, I would just say, finally, I worry big picture kind of patient healthcare system. If I say to my patient who's coming to me and asking for help, I can't help you with this problem, and I drive them away, then they're going to maybe they will return to full use on the streets. Maybe they will have an overdose. Maybe they will have a catastrophic relapse. They'll be in and out of the emergency room. They'll be out of care. They won't have a PCP anymore. And so to me, that is also harm to the patient. And I think by, taking this leap, trying this unproven, unresearched thing with a patient that Mass Health won't approve is reasonable because I know them well. I've been their patient for a while, and perhaps I can actually help them and prevent these other harms. Thank you.
Do we have time for rebuttals? I think that was like 20 minutes. All right, all right. So Dr. Sorcinelli, you bring up a lot of great points. I probably left out an important part of patient care in my argument, in that autonomy and the individuality of patients is super important. The need to individualize patient care when thinking about optimal treatment of pain and suffering in patients is super duper important. It's the same for bread and butter diseases, like you were saying, for diabetes, hypertension, mental health disorders. So I appreciate that all things should not be cookie cutter and black and white medicine. When I first started training in residency, I was a young, energetic, impressionable doctor with a sparkle in my eye and a skip in his step. One of my first days being Dr. Ryan Dono, one of my favorite attendings in residency, told me that my new favorite color is now gray. Nothing is black and white in medicine. There's a different approach that probably should be taken when caring for each and every patient. Everyone has their own story. Everyone gets to where they are in life on a unique path. To prescribe predetermined plans to any illness in their lives will more than often not end in failure, unless it's a slam dunk like strep throat, my favorite diagnosis. I appreciate that approaching chronic pain in the setting of opioid use disorders is very much an instance where each case has its own individual solution. When I reflect on my fears, I think about the catastrophic outcomes these fears could produce. My fears of burnout, loss of license, and patient harm are some of the more powerful fears I face in my role as a physician, and these weigh on my soul pretty heavily. Our society and medical system is inundated with way too many things. There are too many workless tasks for me to deal with, too many external distractions, too many insurance companies telling me that not to do this or that, too many lawyers telling me that I'm a bad doctor, too many EMRs to enter, too many bosses telling me to see more patients, too many patients asking me to care for them, and too many voices in my own head saying you need to spend more time with your family and less time dealing with all this other stuff. When it comes down to it, as strong as I may appear, I'm a fragile, delicate flower these days with all of this on top of my shoulders. The smallest insult could easily be the one that makes me wilt and fall apart. The thought of taking on prescribing opioids often is a crushing, complicated endeavor that makes my brain really hurt. And so can you really blame me for not wanting to do this? If I take on too much, I'm worried that I'll become less of a physician. My decision-making capacity could be worse, and my patients may have poorer outcomes. It's a decision that I don't take lightly. With all of that said, I do think that perhaps I should do better in embracing a patient-centered approach when caring for patients struggling with chronic pain and addiction. I'm willing to consider it, but it is definitely not the easy road. And it's going to require that I create a system that supports myself, my clinical team, and my patient, because we all need to get through this together. And only with the appropriate system and structure behind it all should I consider it. Thanks.
Can you hear me? I don't know if I really have a great rebuttal to that. I mean, I hear what you're saying, and I guess I would just go back again to the feeling that we get when we partner with our patients and we're the doctor that our patient needs, and we really listen to them, we connect with them. And I think, again, many of these patients with opiate use disorder have said to me, you know, wow, you really understand what I'm going through. You're really listening to me. Other people are so mean to me. I go to the emergency room and they look at me like I'm garbage, you know. I think for me, those patient interactions make all the other terrible things about medicine worthwhile, you know, the prior auth, the EMR, the clicky boxes. And I enjoy working with these complicated patients. And I think the only way that it will get easier for healthcare systems to manage these complicated patients is if some of us do it. If we turn everybody away who's too complicated, they will have nowhere to go. And if not us in this room, you know, I don't know who's going to do it. So I think we need to stick together and we shouldn't fight or debate too much. I think there's more that unites us than separates us. Thank you.
All right, we actually have a brief second for Q&A to Mia and Ryan, who really sort of, can I get another round of applause for them? That wasn't easy. Dr. Poti.
I just want to say that I was very moved listening to both of you, and I was nodding my head with both of you, and I would want either one of you to be my family doctor. You guys are doing great work. Is there anything different about this case? Because it really felt like iatrogenic OUD. This is a person who had chronic pain. She was prescribed, then she got cut off, and then she was searching high and low for some way to manage. That's so many of our people, right? You hear these stories all the time. I was fine on my opiate. I was always in control. I was on a reasonable amount. And then sometime in the last 10 to 15 years, they get thrown off. And there's something about that that I really react to where I'm like, man, we screwed up early by prescribing too much. And then we have done the last 10 or 15 years of harming people even more. I guess it's almost to Ryan. Is there anything about the iatrogenic nature of this that would make you be able to take her on?
Complicated question because you're asking me to represent an opinion I maybe don't agree with. It's so, I think at the end of the day, for me, when I'm thinking about this outside of my debate points, is really like we need to take care of patients, and especially in this case, holy cow, like they're coming to us honest. Like Mia, you brought up a great point. Like when they're honest and they're forthcoming about like slipping up and using, those are the times where you need to jump in and just embrace the patient, give them a hug, and take care of them, do the right thing, you know. And so, yeah, I hear you. I don't know how I can convince my other self to do such things. I think the hardest part is when people are burnt out. It's really hard to do extra and do more. And so it's really solving the burnout problem and helping embracing docs when they're burnt out and hugging them for that, you know? So.
Hey, I'm Phoebe Cushman from Spectrum Health Systems. I'm going to be brave and take the actual opposite view here, or ask a question that represents the opposite view without insulting anyone. I guess one of my concerns, and I was in primary care for 20 years, and I definitely took care of lots of patients on high dose opioids, and I didn't cut them off, and I welcomed them. So I don't want people to think I'm really like the bad guy. But I guess in some of these discussions, there's certainly this implication that you are mean and uncompassionate if you are concerned about opioid use disorder. And I feel like sometimes we're missing the definitions of opioid use disorder, lack of control, continued use despite harm, craving. And so I know I'm rambling, but my question is, one of the things that I don't understand, and again, I speak from a different place because I do work in a methadone clinic, and I've actually seen a lot of patients, I know Mia does too, I've seen patients who come to me and they say, oh yeah, like my doctor knows I have an opioid use disorder and they thought I was in a lot of pain. And so here's your oxycodone. And I'll say, well, how did you take it? Oh, well, I finished the 40 pills in a day and a half. And so, yeah, they were in pain, but is that safe? So I guess my question is, and this is a big question, is how how do you even decide like what the treatment plan is? Like if they have fentanyl in their urine in a week or two, does that mean the plan didn't work? Like, I mean, I know that we do like treatment contracts and short prescriptions and lots of follow-ups, but is there like what is how do we know where like what are we doing here?
Can you guys hear me? Okay, that's a great question, Phoebe. And I didn't mean to say that people who don't love treating opiate use disorder are mean. I mean, I guess, so I just want to make it clear, I don't think that that I would prescribe pain medications to someone with an active, untreated opiate use disorder, right? Like I would not, and nor should anybody, because it's illegal to do that for, you know, if they're not on maintenance therapy and you're sort of closing one eye and writing a prescription for oxycodone saying I'm treating your pain, but you know they have an active use disorder. I mean, that's against the law. Like I'm not saying I would do that. In my mind, these are patients who are in a on treatment for their opiate use disorder, and also sort of really struggling with chronic pain. And I mean, I think your point about the diagnostic criteria, you know, we already kind of know the diagnosis. I think the treatment plan is a little more complicated. So if it was someone on buprenorphine and I said, okay, I know you have this terrible back pain, we're going to try, this is my real patient, I'll try tramadol. And, you know, they took tramadol for 2 weeks and then all of a sudden there was fentanyl in their tox stream. I would be like, okay, hey, wait, let's reassess, let's back up. I don't think this is working for you. Do you need a higher level of care? Do you need, you know, methadone? I wouldn't continue my unorthodox, unevidence-based treatment without really reassessing. But I wouldn't prescribe these meds to someone who's not in treatment for their opiate use disorder. Okay, sorry, I should have made that clear.
I agree. I think, you know, I forgot what I was gonna say. I think that, I forgot it. It's gone. Forget it. Oh, I
Sorry,
remember.
weird. It like turned off on me. I think the other thing to sort of consider when we think about like the diagnostic criteria, right, is like we created those, right? And there are lots of discussions about the behaviors folks have when they have been put in a situation of being made physically dependent on a substance that is then taken away from them. There was a really great article, I think in JAMA several years ago, talking about this idea of chronic persistent benzodiazepine dependence. And I'm like seeing a lot of my former residents like nod their heads because I feel like our entire clinic is just full of people like this who were started on high doses of chronic benzodiazepines and are now being told that they need to taper. And they then manifest behaviors that may seem similar to a use disorder because they are so fearful of what's going to happen if someone stops it, and they have lost control because we've taken control away from them, right? And so that idea of like loss of control is a little bit fraught when the patient actually doesn't have any control in the situation, right? Like we are the ones clicking sign on the RX. And so I think I appreciate that you brought up that, and I think I would want us to all sort of delve a little bit deeper, right? Like, of course, we can go through the DSM-5 criteria and sort of say you do or you don't meet a, you know, criteria for a use disorder in this moment, or it's in remission, or all of that. But like push deeper, like what is motivating these behaviors and what is the flavor of those behaviors, right? Because is it that the person actually is having an impending return to use that's scary, then we should reassess. Like we need to stop and reassess. Or is their behavior driven by the fear that we're going to cut them off, right? Because those to me are just like very different patient approaches. And like to Chris's point, like document all of that.
I also don't think there's a right or wrong answer in any of this. Everybody's got their own line in the sand that they're comfortable with. And I think if you go down that path with somebody, I think setting clear expectations and goals and reevaluating those and being super clear about it. Because if you're not clear about it, then it gets into this really uncomfortable conversation. But if you set up clear guidelines and we're going to do this and this is what we need to see happen, then I think that's okay. But also being flexible during that process too. But
Michael.
This is great. Very moving, because it does, pull us into the exam room and into those discussions and into the sad conditions of our patients' lives and our own tension. So I think one way of approaching it that Chris Shanahan alluded to but didn't get into was this PEG, this sort of quality of life questionnaire that gets into what does the patient care about, what's their function like, what's the daily intrusive pain level, what are their, and if you're attending to those things, the rest kind of peels away, and you're helping, you're marching with the patient through a challenging life, and you're trying different means to the end, and maybe they're pharmacologic, maybe not, and if you're careful, you're mitigating risk, and I'm not answering the question, do pure mu agonists have a role in this situation? But I think you feel like a doctor and not like a prescription machine if you're taking that approach. And yes, it is a little more time consuming. Yeah.
Hello. Do you hear me? So I'm Adam Chamberlain. Thank you. I'm from Bay State and BHN. My question is basically, so when I think about these patients with both substance use disorder or opioid use disorder and pain, I think the less likely scenario is that they are connected to primary care. In my experience, the more likely is that they do not have a PCP and maybe never have, and they're seeing you either in an OTP setting or an OBOT. And I'm wondering what your advice would be in that situation. I guess first of all, is it possible? Is it in the regulations possible to manage people's pain with full opioid agonist scripts within either of those settings? So then there's a quick question. The answer is no.
I think no is the answer to that question.
Yeah. So
Yeah.
then just
I mean, like you as their OTP doctor, could you write them a prescription for oxycodone? I mean, I think you, so I actually think though, this is really weird. I think the insurance company maybe wouldn't know if you did that. Right. Because I'm not saying you should. Jeff Baxter is giving me the evil eye. Don't worry, Jeff. I work at Jeff's methadone clinic. I will not do this. I promise. But methadone in the methadone clinic does not show up in the PMP. And, at Greater Lawrence, we have this one famous story that's gone down. It's like the story that makes us all want to die. We had a patient who for 3 years was going to the methadone clinic in town and also coming to us and getting a full monthly prescription for 2 Suboxones a day. And weirdly enough, the insurance company did not say, hey, wait a minute, this doesn't make sense. Right. Exactly. How we found out is the patient ended up in the hospital and said to the residents, oh, hey, I need my methadone dose. And they were like, don't you mean your buprenorphine dose? And he was like, no, I go to the methadone clinic. So I mean, you could, I don't think you ought to.
I would argue
that's OBAT as well. What if you're an outpatient?
Right. I mean, that's
Also
what
not
we are. So we are OBAT. We're PCPs and OBAT doctors, often for the same patient. And that's what I was sort of thinking about when I said maybe I would try it for certain patients, like my patient who has terrible back pain. She's on 4 Suboxones a day and she's done all the water therapy and she had surgery and the blah, 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 this, that. She's done all the things. And I thought I would try it, and Mass Health laughed in my face.
Sorry, to clarify, are you thinking by OBAT, you're sort of thinking like a standalone, like a clean slate type place that does not have primary care sort of explicitly there?
Not a primary care facility.
And so
I don't think they would do it.
I would argue You see a fair amount of patients that do have primary care providers. You can probably identify some of them. We were talking about this earlier, like there's a black box with methadone and they go to methadone clinic and then the primary care is outside of that. And so find some friends in the area that are primary care docs that often your patients are at that place and buddy up with them and find ways to get them into primary care if you need to do such things. We're happy to work together.
Shanahan, Boston Medical Center. This was an excellent.
A little closer.
Talk to the ice cream cone. This was an excellent talk. Thank you. The consultants at McStaff regularly tell me that one of the hardest cases that they get are these combined substance use and pain patients. So it's a real issue. I'll just say one thing simply. If we've got researchers in the room, or if you have colleagues or researchers, please tell them that they need to research this because we don't know what to do. And it's complicated and we need some help. So we really need some research in this area, both at the practice level and all the way up to, to basic science if necessary. Thank you.
Zoe.
Hi, Zoe Gordon. I'm at Lynn Community Health Center. First of all, wonderful job. But I'm a huge fan of the Curbsiders Addiction Medicine podcast, and there was one recently addressing this. And one thing that they mentioned was using Suboxone as first line for pain management, specifically like in the VA, I believe. And this was a little bit ago since I last listened to it, but was now like protocolized as first line. And I was just curious, in your experiences, kind of that approach as well, because it was something I think I had more grappled with whether to start like full opioid agonist versus like using Suboxone for pain management.
Funny, Zoe, I just listened to that episode again, like on Monday, because I was thinking maybe there is evidence that I just am not aware of. But even that person that they were talking to, who's like palliative care, addiction medicine, internal medicine, like quadruple board certified, she was like, I wouldn't do this. I wouldn't prescribe the opiates to people on buprenorphine. I don't know, Ryan. I can't remember the last time I've started a patient on like oxycodone for chronic pain. It's been a long time since I've done that. And so, if I'm talking to a primary care patient of mine who's not a OBOT patient of mine, I would definitely offer Suboxone preferentially, or, Belbuca